I wanted to talk about how I think about cardiogenic shock. The most common causes are going to be heart failure and heart attack. You might have to broaden your differentials into myocarditis, medication induced, such as calcium channel blockers, beta blockers. Stress induced cardiomyopathy could be from thyroid storm, tachycardia from AFib with RVR, or sepsis. You want to check the vitals. Often you'll see systolic blood pressure less than 90, narrow pulse pressure, cool extremities. You'll see an echo with the cardiac output that is decreased, and that makes sense. It falls into the physiology of cardiogenic shock, which is decreased cardiac output with increased other parameters such as increased SVR, increased pulmonary capillary wedge pressure, increased SVO2 as well. So when you see this, you want to resuscitate the patient. If they're volume down, you can give fluids, but if they're hypervolemic, you would avoid it. You want to keep their mean arterial pressure above 65. So ACC and AHA, the first line is levofed. If these aren't working, then that's when you begin to start trying other inotropic support, such as dobutamine and milrinone. How to think about dobutamine and milrinone. So there's a do-re-mi study, which is like the best randomized control trial between the two, and it showed equivalence. So it was an equivalent study in equivalence in hospital mortality, need for CPR, and equivalent escalation to mechanical circulatory support. So there's not really much of a difference between the two. However, in terms of how they are used, dobutamine is more flexible. It's quick on, quick off. Half-life is shorter. So it's especially useful in cardiogenic shock of new onset. So then you can titrate it more easily. It's dose dependent as well. So from doses of 2 to 10, it has more beta activity, and then from 10 to 20 has more alpha activity. So it can be used for cardiogenic support. However, at higher doses, it can drop the cardiac output because it acts on the alpha. So there's also milrinone. This bypasses the beta receptor. It lasts longer half-life, and it's not as flexible. So it's more used for established cardiogenic shock. If these pressors are not working, it's time to build a robot person. It's time to employ mechanical support devices. The problem with these devices is currently there's no randomized control evidence that these mechanical circulatory support improves mortality. There is, however, an arrest trial that out of hospital cardiac arrest, eCPR with mechanical support devices does improve mortality. These devices can be ordered in terms of the amount of cardiac output that the devices can offload. So in order, they go from balloon to Impellas to tandem hearts to ECMO in terms of the amount of fluids they can relieve. So a balloon can relieve 1 liter of fluid, and then Impellas like around 2 to 5, and ECMOs can relieve 10 liters of cardiac output. When initiating mechanical assist support device, there needs to be an interdisciplinary team. Oftentimes, there's going to be a cardiologist, CT surgeon, heart failure, and intensivist. However, overall, the bottom line in cardiogenic shock is to echo the sick first, start levo, then start other drips while discussing with the shock team what the next steps are. Thank you.